Okay, welcome to the last session of the first day of our conference, Management of Acute and Post-Acute Alcohol Withdrawal in RAAM Clinic Settings, presented by Dr. Meldon Kahan. Before we get started, just a couple of notes or things to note. I'm sure you know this already, but please put questions, comments in the chat at any time. Mel will endeavor to answer them as he can, whether during the presentation or after. There'll be lots of time at the end of the presentation for comments and discussion. And if you wish to use the Q&A feature, you can, but we suggest the chat might be easier because then everyone can see everyone's questions. And I think that's it. Oh, and then at the end of the session, I will be posting a link for the survey, which we would appreciate you filling out. Okay, I think that's it. Mel, do you want to take it away?
Yeah, thank you, Lori. I'm Mel Kahan. I'm medical director of PHI, and I've been an addiction physician for many, many years, although I'm actually retired from clinical practice as of last year. I'm going to talk about management of acute and post-acute alcohol withdrawal in RAAM clinic settings. Next slide.
Yeah,
Disclosures. I received an honorarium from Indivior for participating in a panel on opiate agonist treatment. Next slide. Okay. Learning objectives explain the rationale for treating alcohol withdrawal electively as a therapeutic intervention rather than as an emergency intervention. Discuss clinical considerations in managing alcohol withdrawal in a RAAM or outpatient setting, and outline a protocol for management of post-acute withdrawal syndrome. Next slide. So alcohol withdrawal as a therapeutic intervention. The prevailing view is that alcohol withdrawal is an emergency that must be treated to prevent complications. And the usual setting for treatment is the emergency department, sometimes the withdrawal management center. The goal is to prevent seizures and other serious complications of alcohol withdrawal. But alcohol withdrawal management can also be viewed as a therapeutic intervention. That is a step towards recovery, towards abstinence or reduced drinking. Alcohol withdrawal, besides the physical symptoms of tremor and sweating and seizures and so on, there are marked psychological symptoms, anxiety, insomnia, and cravings, and these symptoms are very quickly relieved by alcohol. And these symptoms compel patients to continue drinking. At the onset of withdrawal-related anxiety, patients know that if they drink, they'll feel good, and then they're starting on that same path. And this, of course, is exactly what happens in opiate use disorder. Opiate withdrawal compels patients to use opiates to relieve the withdrawal symptoms. And of course, people who no longer need to drink to relieve withdrawal symptoms, if they're motivated towards abstinence or reduced drinking, they'll be more likely to engage in counseling and medical treatment. Next slide. Is it effective in improving drinking outcomes? That is elective withdrawal management. We know that withdrawal management is effective at preventing seizures, but does it actually improve drinking outcomes if done in a therapeutic setting? Evidence is very limited on this. Nobody's really looked at it that much, but promising. And in fact, Jennifer at Women's College Hospital has completed a retrospective chart review of 73 patients who were admitted electively to the short stay unit, which is a 24-hour stay, and found that at 1 month post-discharge, 45 out of 50 patients reported reduced drinking and improved well-being. 23 were lost to follow-up. And again, these patients were admitted electively who had committed to abstinence, but they found that withdrawal symptoms made it difficult for them to stop. A retrospective chart review of a low-barrier outpatient clinic also reported good results with elective outpatient withdrawal treatment. Next slide. What about specifically RAAM clinic settings as management of elective withdrawal? Limited but promising evidence that RAAM clinics that can effectively manage alcohol use disorder, but no evidence that they treat withdrawal specifically. A retrospective cohort study done at Ottawa Emergency Department, RAAM clinic associated with the Ottawa Emergency Department found that patients who were referred from the ED to the RAAM clinic had a marked reduction in repeat ED visits at 30 days compared to baseline, and a self-reported reduction in drinking and improved mood. A similar study done at Toronto Western Hospital had the same results. Patients who attended the Toronto RAAM clinic had reported increased rates of abstinence and reduced alcohol consumption. Next slide. Well, RAAM clinics versus EDs, why should we treat alcohol withdrawal in the RAAM clinic when we can just send the patient to the ED, which has, of course, much better resources? Well, part of the problem is that patients with alcohol use disorder are often very reluctant to go to the emergency department, where they face very long waits, where they commonly perceive that there's a stigma, that the healthcare providers are not happy to see them, and where withdrawal is often undertreated. And this is shown in evidence. One retrospective cohort study of 235 patients who were treated for alcohol withdrawal at one ED in Vancouver, I think it was. The average total dose of benzodiazepine received was only 6 milligrams. That was over their entire stay of lorazepam, which is equivalent to only 30 milligrams of diazepam. And not surprisingly, the return rate to the emergency department within 7 days was 32%. Don't know why the patients returned, but untreated withdrawal, relapse to drinking, and then going into withdrawal again is a very strong possibility. Next slide. Another issue about where to treat RAAM versus EDs is that some patients, even if they want to quit drinking, are afraid about stopping drinking, not just because of withdrawal, but because of how they think they're going to feel after they stop drinking. So when patients in withdrawal drink alcohol, they experience rapid and marked relief of anxiety, and that can cause some patients to believe that if they don't drink at all, they're going to experience severe anxiety. So you want to assure patients, number one, that benzodiazepines quickly and effectively relieve withdrawal symptoms. Next slide. And also explain that although alcohol is a sedative, paradoxically, heavy sustained drinking actually increases anxiety and insomnia by revving up or triggering the nervous system. With abstinence and reduced drinking and medications and counseling, the nervous system returns to normal within weeks, and that leads to improved mood, less anxiety, and less insomnia. In fact, the mood is considerably better than when they were actively drinking. Next slide. So treating a withdrawal in a RAAM clinic. Necessary supplies, well, you need a healthcare worker on site, a nurse, an NP, physician. It needs to be open for as long as possible, at least 5 or 6 hours, so you can get several doses of diazepam in. Should have medications readily available, including diazepam and lorazepam and thiamine. There should be a plan for a rescue plan. If the patient needs emergency department management, there's a ED within reasonable distance. Next slide. The ideal candidate for RAAM treatment is that the patient expresses a sustained interest in reducing drinking or abstinence. If the patient really doesn't want to stop drinking, there's no point in treating withdrawal electively. Patient should report frequent or daily withdrawal symptoms, typically occurring at a predictable time from their last drink, which may vary from 6 to 12 hours, and these symptoms are quickly relieved by drinking. The patient does not have indications of severe withdrawal, such as recent seizures or emergency department visits for management of withdrawal, is not at high risk for benzodiazepine toxicity, that is severe chronic obstructive lung disease, or on high doses of methadone. agrees to go to the ED or WMS if advised to do so by the RAAM clinician, and ideally has social supports at home. Next slide. So the protocol is to advise the patient to have their last drink the night before, 12 hours ideally. So when they come to the RAAM clinic, they're ready for treatment. They're starting to go into withdrawal. If the patient comes in intoxicated, it will take them hours to be ready for a symptom trigger treatment, and they'll need to be sent home. The protocol is here. It's outlined also in the Medify Emergency Department toolkit for managing alcohol withdrawal. It's 10 to 20 milligrams every hour for a CIWA of 10 or more, or a shot score of 1 or more. There should be at least one objective sign present, such as tremor or sweating. Those are the most reliable signs of alcohol withdrawal. And when the patient is doing well, that is, the CIWA is consistently less than 8, and the patient is comfortable and no longer tremulous, then treatment can be discontinued. Next slide. You would send to the ED. And by the way, I would say that usually, if with careful patient selection, it's not common at all to have to send the patient to the emergency department, but you should be aware of criteria for sending the patient to the ED. That is, the patient's withdrawal is not improving or getting worse despite several doses of diazepam. The patient has signs of cardiovascular instability, such as tachycardia. The patient shows signs of impending delirium tremens or alcohol-induced delirium, confusion, disorientation. Patient shows signs of benzodiazepine toxicity like drowsiness, or the patient has repeated vomiting or profuse sweating, which could cause an electrolyte imbalance. Next slide. So on discharge, if the patient is still in mild withdrawal, that is, they're a lot better, but they still have slight tremor, you can, at your discretion, give them diazepam to take home, such as 10 milligrams QID on day 1, TID on day 2, BID on day 3, and so on. They shouldn't need more than 10 tablets or so, and treatment should go in a tapering dose over a few days. Gabapentin is another option, which I'll talk about. You would want to prescribe anti-craving medication if they're not already on it, and check on the patient every day or two just to see that they're doing well. And remember that the risk of relapse is very high in the first few days or weeks of reduced drinking or abstinence. And you want to have a formal appointment in a week. Next slide. Gabapentin is sometimes used for acute withdrawal. In that kind of scenario, the doses are pretty high, 1,800 milligrams per day or more, 600 milligrams TID. It is less sedating than diazepam and less likely to be misused, but it is less effective at preventing seizures. And the recommendation is for moderate to severe withdrawal, it shouldn't be used as monotherapy. I have not had a lot of clinical experience using gabapentin for acute withdrawal, but it certainly is very commonly used as an anti-craving medication. Next slide. So what about patients with a moderate to severe history of withdrawal? Well, here, a partnership with withdrawal management can really be helpful. Again, withdrawal management, although it doesn't have the same resources as an emergency department, it can keep and hold patients longer than a RAAM clinic, and it has a therapeutic orientation, unlike the emergency department. So the RAAM clinic can work with a nurse practitioner in the WMS to develop a plan for elective admission. So the patient, just like with the RAAM clinic, the patient comes in the morning after having no alcohol for 12 hours or so, and the nurse practitioner will start a symptom-triggered treatment protocol. The WMS can keep the patient for 24 hours or longer, provide counseling, connection to treatment, adjustment of anti-craving medications, and so on. And again, referring the patient to the emergency department if necessary. Next slide. Home detox, this is what physicians have done for decades. Someone reports withdrawal symptoms, you give them some diazepam or something to take home, 10 milligrams 6 times a day on day one, for example, and taper by 1 tablet a day. This is certainly more convenient for the patient, and I must admit, I think we have all done it sometimes. Patients come in to the clinic at 5 o'clock and they're in withdrawal, but they're not really that bad, so you may give them a few. Just keep in mind it's not as effective as symptom-triggered treatment, which gives a much higher dose when the patient is really in withdrawal, that is 20 milligrams per hour. Also remember that tapering doses of diazepam can be sedating if and when the patient is no longer in acute withdrawal. And of course, if the patient has these diazepam pills at home, they may combine it with alcohol. And perhaps most serious, they may find that they actually like diazepam. Remember that many people are drinking in part to control an anxiety disorder, and they find that diazepam helps them just like alcohol does, then you have a problem. CAMH has had a successful pilot of home symptom-triggered treatment with careful monitoring, where they were actually using the CWA scale to treat patients at home, and that has really important implications. That paper is submitted for publication. Next slide. Discharge counseling. So let's say you've treated the patient, they're feeling okay, they're no longer tremulous. You want to tell them, well, now you no longer need to drink to relieve withdrawal symptoms. And if you remain abstinent or reduce your drinking over the next few days and weeks, your mood and sleep and energy level will continue to improve and your cravings will diminish. You need to advise them on steps they need to take to prevent relapse and arrange frequent follow-up. Next slide. Reducing the risk of relapse, again, keeping in mind that the risk is very high in the first few days or weeks of abstinence. Don't keep alcohol in the house. Don't engage in activities that will expose you to alcohol. Obviously, you're not going to go to the bar, etc. Spend time with positive supports who don't drink. Don't isolate yourself, but spend time with family and friends. And have a strategy to cope with cravings. That includes a 30-minute timeout, like, oh, I really want to drink, but I'm going to wait 30 minutes. Often by the end of that 30-minute period, the craving is gone. Mindfulness is very helpful for this. Have a support person that you can call, could be a friend or a relative. If intense, leave whatever setting you're in. If you're just worked up at home and really want to drink, just get out of the house and do something else. Next slide. And of course, connect the patient to resources in the community, the RAAM clinic counselor or yourself or other community services, Alcoholics Anonymous, other self-help groups, counseling programs, and so on. And if the patient slips or resumes drinking, ask them to contact you right away. I mean, it's very common for patients to slip. Often patients need several attempts or more than several attempts to really have sustained abstinence. So you don't want to give up. It's the same with smoking. Patients try repeatedly to quit. Each time they attempt to quit, their chances of success go up. Next slide. Subacute or post-acute withdrawal is characterized by insomnia, anxiety, depression, irritability, poor concentration, and craving for alcohol. It is a true neurological, again, chronic heavy drinking has reset the autonomic nervous system. So these symptoms are not just psychological in origin, they have a neurological basis. The symptoms start after the acute withdrawal has resolved, and they can last for several months or longer, gradually lessening with time. Of course, it's very similar to opiate withdrawal in that sense. Even once the acute withdrawal has resolved, opiate withdrawal patients can feel not good at all for the next few months. And subacute or post-acute withdrawal is likely a major cause of relapse because drinking alcohol will relieve all these symptoms. Next slide. The two medications, or two or three medications that we recommend for this, one is acamprosate. Controlled trials have found that acamprosate is effective for post-acute withdrawal symptoms, particularly insomnia. Acamprosate is not effective while the patient is drinking, but it can be started on the first day of elective withdrawal management. The dose is 666 milligrams TID, lower if there's renal insufficiency. It's a limited use code medication, generally very well tolerated, sometimes with minor GI side effects. Next slide. Gabapentin. Meta-analysis of controlled trials has shown that gabapentin is an effective anti-craving medication. It seems to be particularly effective for the patients we're talking about, that is, patients who experience daily withdrawal symptoms while drinking. And that was a controlled trial that showed that it didn't work that well in patients who didn't experience withdrawal symptoms, but it did definitely improve drinking outcomes in those with high alcohol withdrawal scores. In other words, they were having daily withdrawal symptoms. It also has been shown to relieve insomnia and post-acute withdrawal, like acamprosate. Next slide. A dosing RCT found that 800 milligrams per day was more effective than 900 milligrams per day, which in turn was more effective than placebo. People have different protocols, but I tended to start at around 300 milligrams BID and titrate up from there. Side effects include dizziness and sedation, sometimes depression. Gabapentin can be started while the patient is drinking, although like benzodiazepines, if gabapentin is sedating, that can be a problem if they're drinking very heavily. Gabapentin can be combined with other anti-craving medications like naltrexone and acamprosate. And even though there's not a lot of research on this, the controlled trials that have been done have shown that combination therapy tends to work better than either drug alone. And keep in mind that pregabalin also has some evidence of benefit as an anti-craving medication, and both gabapentin and pregabalin may be effective for patients with comorbid anxiety disorder and alcohol use disorder, which of course is very common. Next slide. Counseling and follow-up. This is for post-acute withdrawal. You want to see patients frequently. Advise patients that subacute withdrawal symptoms, cravings, insomnia, and low mood get better with time. And that, again, if the patient can maintain abstinence for a number of weeks, they're going to feel and function much better than they did when they were drinking. And of course, encourage positive social supports and activities, and avoid triggers to drinking, people, places, and things, as AA said. Connect the patient to community addiction and mental health services and self-help groups. Next slide. Okay, I'm going into cases, and then we'll have time to discuss your own cases or questions. So the first case is a patient who is, quote, ready. This is a 45-year-old woman who has been drinking 1 bottle of wine per day for 1 year since the death of her mother. She reports anxiety and slight tremor in the morning, which is relieved by alcohol, and once she starts drinking, she has trouble stopping. She's on leave from work, and she has a supportive partner. She has had no benefit from naltrexone or counseling, but she really wants to quit alcohol. She's depressed and anxious and feels her life is in a downward spiral. So how would you manage this? I guess you can put comments in the chat or I guess raise your hand. I would say, first of all, that this patient has a very good prognosis. She's only been drinking heavily or problematically for 1 year, and that was at a very clear trigger, grief. She's socially stable. She has very motivated. She is, committed to work. She has a partner. So but she clearly expresses that alcohol withdrawal is a barrier to her recovery. So this is the kind of patient that you really want to try to have this kind of elective withdrawal process. And it should work because, as far as you can tell, she has mild withdrawal. She doesn't have a history of seizures and so on and so forth. So that's how I would view that. Next case. This is a patient a little bit trickier, or definitely more tricky. This is a patient who presents to the RAAM clinic in withdrawal. So it's not elective. The patient is right there and they're having some degree of tremor and sweating. This patient is a 35-year-old man, has a 2-year history of heavy drinking after a breakup of a long-term relationship and loss of a job. Lives alone, not working, and no social supports. 2 weeks ago, he attended the ED for alcohol withdrawal treatment. He was only abstinent afterwards for 3 days and then resumed drinking. And he's much heavier than the first patient, drinking 12 standard drinks per day, and states he would like to quit drinking and go back to his family. Anything else you'd like to know about him, and how would you manage this? Maybe you can again raise your hand or put comments in the chat. I'll wait for a minute. Oh, there's something in the Q&A. Okay, sorry, I will just answer this questions. There's 3. Clarifying with your suggestions of working with withdrawal management units that they do not administer IV therapy, have oxygen, or can manage airway for more aggressive acute withdrawal management treatment options. Important to look at withdrawal history, comorbidities, and risk of seizures. That's absolutely true. Withdrawal management cannot do the things that the emergency departments can do. So patients who are in very severe withdrawal, they're very, very tremulous, they're pre-DTs, they're sweating profusely, they're confused, they're aggressive. They usually need intravenous benzodiazepines, maybe phenobarb. And so if they have comorbid problems, like they're also using opiates, that also becomes much trickier, and you would need an ED setting for that. I think withdrawal management units are very good at identifying those reasons to send the patient to the ED. So that's very, very important. What are your thoughts of arranging ED setting support for acute withdrawal management? Could addiction medicine consult teams collaborate with RAAMs to arrange and support? Yes, that is very true. I think that there are hospitals, a minority, but there are hospitals that have really good addiction medicine consult teams in Toronto, at St. Mike's and St. Joe's, for example, Michael Guerin. And you could arrange with the doctor there to send the patient to the emergency department, and then they have options for, especially if they have a severe history of withdrawal, you can support them with intravenous benzodiazepines, phenobarb if necessary, with follow-up, of course, afterwards in the RAAM clinic. So yes, ideally, RAAM clinics, our EDs would be better at managing withdrawal, and that, of course, is a goal of the Center of Excellence in Ontario. Their goal is that all EDs will be able to manage alcohol withdrawal in using symptom trigger treatment and initiate treatment, anti-craving medications, and connect patients with community services. And then there's another question. Would you or anyone in the audience have experience using carbamazepine for acute withdrawal? I do not. I know that it has some evidence of benefit as an anti-craving medication, but I'm not as familiar with it for acute withdrawal. Anyway, there are more questions. Let me just have a look here. Chat seems to be disabled. Oh yeah, there is a comment. When was the last drink? This is again about this case who presents to the RAAM clinic in withdrawal. You want to know when the last drink is. that will give you a sense of the course of withdrawal. If the last drink was only 6 hours ago, then the patient is going to get worse. If the last drink was 2 days ago, maybe the patient is over the worst. Any history of complicated withdrawal? Yes, he was in the emergency department. What happened there? Does he have a history of withdrawal seizures? That's also a very, very important question. And then comments about the chat not working. Okay, so I think that my comment about case 2 is that this patient is more severe. I think that he probably wouldn't be able to be successfully managed in the RAAM clinic. You might give him a dose or two, but ultimately he's probably going to need to go to the emergency department. I would say that you would hope that the emergency department would be aggressive in giving him symptom-triggered treatment or phenobarb so that the withdrawal is completely resolved. That's number 1. Oh yeah, can you move to case 2? Yeah, case 2. So the emergency department thing didn't work. So you want to make sure that when he goes to the emergency department this time, hopefully he'll get more aggressive benzodiazepine treatment so his withdrawal is resolved. That's number 1. Number 2, if they don't prescribe an anti-craving medication in the emerge, then you want to see him immediately after the emerge visit. Or maybe he should go to withdrawal management so you can give him an anti-craving medication. Number 3, he appears to be committed and motivated. So you want to take advantage of this, connect him to community supports, again, either through withdrawal management or counseling in the RAAM clinic, self-help groups, and so on. So I think, again, even though you may not be fully able to treat his withdrawal in the RAAM clinic, you can try and work with the emergency department to ensure that he does get appropriate treatment and that his withdrawal has completely resolved before sending him on. Next slide. Another more complicated scenario, 27-year-old woman. She lives alone but is close to her family. She has a 4-year history of binge drinking, 1 week on and several weeks off. The binges are becoming more frequent and severe. She has had 2 withdrawal seizures. Next slide. Every time she goes to the emergency department, she's given outpatient scripts for diazepam for a few weeks. And that now the family doctor has continued to prescribe ongoing diazepam as withdrawal seizure prophylaxis. And the dose has escalated over the past year. By the way, this is a real case sent to me by my colleague, Katie Dunham. The dose has escalated over the past year, and now she's on 10 milligrams QID plus 1 tab PRN. She sometimes uses more benzodiazepine when she's anxious, and she relapses to alcohol use if she doesn't get the renewal right away. So what are we dealing with? What are the possible diagnoses, and how would you manage this? Again, going to the chat. And there are some great comments here in the chat. Just moving back a bit, can you give the doses of diazepam to bring to the ED and fax consult to the ED and give patient multiple copies? Make sure you inform them of the diazepam given, or they may turn the patient away. I think those are very, very good points. That's from Sam Merrifield. I think that we're going back to case 2 now, if the patient is in withdrawal, and you have diazepam available, give them some right away. Send them to the emerge, but tell them that even if the patient appears somewhat better, their withdrawal has not been completely treated and they need emergency department management, and outline your approach as much as you're able to for the emergency department and arrange follow-up. I think that ED docs will definitely appreciate your involvement as a addiction expert in helping to direct that care. So now there's a comment about the case 3, benzodiazepine use disorder. Absolutely. This is a very tricky situation. This patient has alcohol use disorder. That's what they started off with. And now with her ongoing outpatient scripts for diazepam, she also has benzodiazepine use disorder, and she likely has a good chance that she has anxiety disorder as well, complicating everything. So this creates a very difficult, vicious cycle. The patient takes diazepam. When the patient runs out, she turns to alcohol to treat her benzodiazepine withdrawal and her anxiety that accompanies benzo withdrawal. And then that she drinks more alcohol, and she uses diazepam to deal with the withdrawal from alcohol. So everything escalates. And it's made worse, not better, by the prescribing of diazepam. And so what do you do about that? And on top of it, she probably has an anxiety disorder triggering the whole thing. You could increase her benzo tapering, and be sure not to taper below baseline dosing when managing alcohol withdrawal. So taper schedule for benzos, 10% reduction every few weeks. I think those are all good ideas, often problematic, or the patient may not accept it. If she has the feeling that diazepam is incredibly therapeutic, she needs the diazepam to treat her alcohol withdrawal, and she can't exist without it. Then it becomes much harder for her to accept the idea of a taper. If you do the taper, it should be under conditions, frequent dispensing, a couple of times a week, or if that doesn't work, even daily, with the understanding that if she continues to run out and continues to drink or combine alcohol with diazepam, then the taper will end. Then there's a comment, she may benefit from an admission to a concurrent disorders treatment program. I personally think that's the way to go, an admission to a treatment program of some kind. Concurrent disorders are a program that really focuses on looking at underlying issues, because she's going to need days and days as an inpatient to help sort this out medically, and also to address the underlying issues of anxiety and benzodiazepine use disorder. A comment from Dr. Merrifield, yes, use limited prescriptions daily, witness to weekly dispense, and of course, treat the underlying anxiety with medication such as pregabalin, lots of psychoeducation, and grief counseling. Yes, absolutely. If that patient is triggered by grief. And a comment from Dr. Merrifield, the need for slow and patient-centered benzo tapers. And this is exactly the way to go with tapering. But this is aside from alcohol use disorder. Alcohol complicates everything, but if alcohol is not involved, then the way to deal with benzodiazepines is a slow taper, flexible, patient-centered. There is evidence that rapid tapers can have very bad results, including depression and suicidal ideation. So I think that's a very good comment there. Work with the family doctor and ensure anxiety is treated alongside the alcohol use disorder and the benzodiazepine use disorder. Close follow-up. I think having an empathic and close relationship with the patient is key, because it may take her a while to come around to the idea that she needs treatment and that she's better off stopping the benzos or tapering down on the diazepam. Adding gabapentin, these are all great ideas as an adjunct to taper is a really good idea as well. I think there is evidence from case series that gabapentin is helpful in managing benzodiazepine tapers. Unfortunately, not a lot of research on this, but the research I've seen has found that gabapentin is a good adjunctive medication to help with tapering down on benzodiazepines. So lots of good advice or suggestions here. This patient has a combined benzodiazepine and alcohol use disorder. Management could include, and an underlying anxiety disorder, probably. Management could include benzodiazepine tapering with careful, frequent dispensing twice weekly or more often than that, if necessary, as long as the patient commits to trying her best to be abstinent and not run out of the medication early. I think that if outpatient tapering approach doesn't work, then an inpatient admission would be definitely warranted to a concurrent disorders program or just a regular residential withdrawal program if necessary. So that is it for the cases. These are my references. Next slide. So any other issues that you want to bring up or raise, you can put in the chat or ask about by raising your hand. I'm just trying to look through if I've addressed all the questions that were in the chat. And yes, okay. Any questions or comments? I see a question here. Okay, yes, this is a question. A clinical scenario I've encountered not infrequently in a RAAM is what to do with individuals who drink daily, but only in evening hours. So sometimes in large quantities, but don't experience significant daytime withdrawal symptoms. And they have they don't, yeah, and they haven't had an evening without alcohol in a long time. So how do you deal with that? Well, I would say that, this is very common, and we know that withdrawal is tremendously variable. Withdrawal is, of course, associated with the dose of alcohol consumed, but even within that, there's a lot of variability. So if you have a patient who drinks every evening and reports no withdrawal symptoms during the day, it's possible that they don't experience withdrawal and they wouldn't necessarily benefit from the selective withdrawal. I mean, I guess especially if you see them and they haven't had any alcohol since the evening before and they're not tremulous, it may be that they just don't have alcohol withdrawal. And in that case, you would offer them other treatments such as naltrexone and counseling and so forth. Those patients can be very difficult to treat because often their drinking is simply habit. They're used to it, and they find that it's sedating them and they just enjoy it. And maybe they have a setup where they can continue to drink in the evening without serious consequences, but they are at risk for medical complications such as liver disease and so on. But there certainly are people who, even though they drink heavily, are not reporting withdrawal symptoms. And then there's comments about how do you manage with elderly patients and how do you treat it medically versus older patients, younger patients? Well, certainly I think in elderly patients, I think Dr. Merrifield commented that diazepam is maybe less preferred than lorazepam. Diazepam is metabolized in the liver to active metabolites. And with elderly patients, there's a prolonged, but they don't clear the diazepam as quickly as younger patients because they have less hepatic reserve and capacity. And they also have more, they have less CNS reserve. So they're more likely to get sedated and so on with diazepam. So I agree with that. Lorazepam is preferred. one problem with lorazepam is that it's not as long acting. So you can't just necessarily send patients home, say your withdrawal is fine, because they may get worse the next day. So I would, there's other great comments here. Remember to ask about diet. There is a need to give thiamine, and that is important to do in a RAM setting, and remind the emergency departments to give thiamine. Wernicke's and Korsakoff syndrome is underdiagnosed, and thiamine is extremely safe. So we should routinely ask for that. And then another question about disulfiram as an adjunct. Disulfiram, what a great question. There is good evidence that disulfiram is effective when prescribed in a particular setting, and that's when it's dispensed by someone close to the patient. It could be dispensed by the spouse or a friend or a pharmacist or even the clinician. I think that the evidence suggests that when it's done in that way, it is actually more effective than naltrexone or acamprosate. And interestingly, it actually reduces cravings to a greater extent than naltrexone. And the idea is that once a patient takes that pill of disulfiram, they know they can't drink. So they just stop thinking about it and the cravings go down. It's when you have the option of drinking that's when the cravings are worst. So I think disulfiram is probably an underused thing. I think giving disulfiram to patients who live alone and so on and so forth and don't have anyone to dispense it may not work as well, but certainly for socially stable people with partners and family and so on, it's really good. Question about prescribing the cardiovascular risks of disulfiram. The risks are primarily if the patient drinks. If the patient drinks while on disulfiram, they can become quite hypotensive, and they can also get vaguely induced arrhythmias. So if you have someone who is on antihypertensive medications and older, I think that what you're titrating is fear. You want the patient to be afraid of drinking if they're on antabuse. And if you have a older person who's pretty responsible and so on and understands the risk, I think it's reasonable to try it. Inappropriately sending cognitive versus ruling out B12. There's another comment about, I guess, cognition. Certainly in older patients, there can be an alcohol-induced dementia, and often that dementia can improve, at least to some extent, if the patient is abstinent. There's some recovery. The neurons, at least the axons of the neurons, can actually grow back again to some extent with stopping drinking, but you want to look at other problems such as alcohol withdrawal. And then there's another question about oxazepam. Oxazepam is an underused medication. Its main advantage, oxazepam is a metabolite of diazepam. Its main advantage is that it doesn't give the really nice feeling that diazepam does. So it has less abuse potential, but it's an intermediate acting benzo that doesn't last quite as long as diazepam. So that's why we use diazepam in alcohol withdrawal. And I think that I've answered or addressed many of the questions, which were fantastic. Those questions really went into a lot of important things. Any other questions or comments? I think, Lori, do you see any other ones?
There've been many comments and questions. I don't see any new ones.
All I'll say is that, the RAM clinics are continuing to do a really important job. They're often the only thing available for patients in many communities. And I think that, the whole point is that alcohol withdrawal can be treated effectively, both acute withdrawal and post-acute withdrawal. And so would encourage you to explore that with patients. You want to ask them what time of day do they drink and why do they drink. If they say, I drink it, sometimes patients don't even know they're in alcohol withdrawal. They say, I start to drink at 2 in the afternoon. I'm feeling really anxious. And as soon as I have that first drink, I feel better. You want to ask them, well, what uh, are you shaky at all? When you hold a coffee cup or whatever. And if you're not sure, admit them anyway. Try the elective withdrawal. And if they come in and their CWA scores are 0, then that's fine.
Mel, there is one question. At what point do you consider reporting patients to the ministry when they have recurrent and frequent relapses? Do you wait until you have firm evidence or admission of drinking and driving?
Yeah, great question. Very problematic for a lot of doctors. I think the reasons to report someone to the ministry are there's two parts to this. One is if they acknowledge that they're drinking and driving, if a relative or family member or somebody says that they're drinking and driving, or if they're driving regularly and they're drinking every day. And it's not plausible that they're not drinking and driving. So these are some of the circumstances where you might consider reporting. The ministry does have this thing of, if they don't agree to participate in treatment, then you can report them. But if they do agree, if they say, okay, I'll stop and I'll engage in treatment, then I think it's reasonable to give them a grace period. You can say, okay, you're going to take naltrexone and you're going to go to AA and you're going to see me and I'm going to monitor your drinking with liver function tests and maybe even test your alcohol use with oh my God, how can I forget that special test? Uh, Somebody remind me what that test is that looks for alcohol within the past 5 days. I'm having a mental block about it. But anyway, you want to monitor their alcohol consumption, and if they comply, then that's really good. But if they don't comply, then I think you can report them to the ministry. I would say that reporting to the ministry is going to get the patient very angry, but in my experience, sometimes it often has really good results. Especially with men, especially with older men who are very pissed off that they can't drive. And then they work really hard to not drink so they get their license back. And even after they get their license back, then they're feeling a lot better and they just maintain their abstinence. They can get their license back in 6 months if they participate in a treatment program, and 1 year if they don't participate in a treatment program, with a letter from their addiction clinician saying evidence suggests that they're not drinking or they're not drinking and driving based on gamma GT and reports from family members and reports from the patient. So I know that it's a point of real patients getting very angry, but it is you can tell the patient that it's not your decision. It goes to a panel. You have no authority to take away someone's license. And if they don't agree with it, they can argue with the panel, which won't get them anywhere. But I think we shouldn't feel too bad about it because often it ends up being a really good thing for the patient.
Mel, there's an additional question to that, which you may inadvertently have answered, but how would you deal with a patient with AUD who is still driving with a suspended license? So their license has already been taken away.
Well, I think there's 2 points to that. If the patient is not, if they're drinking, if you think that they're drinking and driving, then I guess you can report them to the ministry or police. I'll have to ask about that because then they're putting other people at risk, and then you are allowed to break confidentiality. But if they're drinking, if they're driving with a suspended license and they're not drinking, or they say they're not drinking, I don't know if you can actually report them to anyone at that point. That would be my quick answer, but that would be a question for the listserv. Be very interested to know what the listserv says about that. I think that any more questions on drinking and driving? What I did was to report to MTO again. Okay, and what did they do? Just out of curiosity. This is so this is a patient who's driving with a suspended license. I don't know, maybe that's a criminal offense and they could look into that. It was last week. I think there's nothing wrong with reporting to the MTO again. They already suspended his license, so you're not breaking confidentiality. You're just saying he's still driving. So it'll be interesting to see what the answer is to that. I think we probably covered everything. Maybe time to wrap up.
Yeah, well, there's only 2 more minutes, so if you didn't finish everything, there's not much more opportunity. I hope people will fill out the evaluation. There's an evaluation for this session and also for all of today, and I put them in the chat. Thank you so much for attending, and hopefully some of you will be coming back tomorrow. Sessions start at 8:30 a.m. tomorrow morning. So any last thoughts, Mel?
No, thank you all for attending. Fantastic questions and comments. I think that, again, we talked about all the negative and problems with addiction, but it can be incredibly satisfying when you have someone with alcohol use disorder who has finally engaged in treatment and is doing a lot better with recovery. Their whole lives are transformed often, and they're very, very grateful for the care that they have received.
Okay, so that should be it for today. Thank you very much. Enjoy your evening and hope to see some of you tomorrow.